only mode.
Hello everyone, we'd like to thank you for joining us for MD Everywhere Presents RCM Best Practices webinar. This will be presented by Michael Leiter. We thank you for your attendance today. We ask that if you have any questions, everyone is muted during the actual call, but there is a question box in the GoToMeeting webinar panel, so please do enter any questions into that panel if you have any. We'll address any questions at the end of the session. Any questions that we do not have time to answer today, we will follow up on with you later. So please enter those as you feel free throughout the training, throughout the webinar, and we'll answer them at the end. Mike, I'll go ahead and turn it over to you. Thank you for your time.
All righty, thanks, Leonard, and thanks everyone for joining today. I'm going to hop right on into it and get into our review. Just want to get the presentation to work. So for revenue cycle management best practices, I wanted to take a little bit of time and go over historically, over the past 5 years, some of the process flows and enhancements that we've made within the industry, and then what we're looking to do for 2014 within the revenue cycle process. A lot of the focus I'm going to create today is going to be around patient engagement and the role of the patient as a consumer and what that consumerism is setting the expectation for the patient moving forward. Talking about ease of appointment scheduling, ensuring that your patients understand their responsibilities, creating an ease and an enhancement of modalities for your patients to make their payments, and then what can you do to actually create that patient engagement and utilize it to grow your practice volume moving forward. I wanted to discuss front-end processing. How can we create automated tools to deliver a knowledge-driven revenue cycle, including eligibility verification, enhancing modalities for collection of time of service, streamlining your charge capture, PQRS capture, and then something that's going to be, I think, really critical for us moving forward and creating that denial mitigation strategy on the front end to stop the defects from occurring. I also want to speak a little bit on managing your provider's credentialing and enrollment status, building a technology-driven claims processing strategy to where we're utilizing computers to do the work that a computer can do and not using our human capital for that investment. Ensuring correct payment through payer contract compliance. And then since it's not going away and it's actually going to happen this year, we're going to talk about ICD10 preparation and readiness for one of the biggest impacts that hit healthcare in the last 30 years. So what I want to start off with is just kind of speaking a little bit about the historical approach to revenue cycle management. I mean, historically, it's involved, the patient calling in, making a schedule for an appointment, or in lesser circumstances, a walk-in. The patient being seen, the care being delivered, a provider, probably mostly by memory, completing a super bill, sending that to the front desk, capturing the charges, submitting that bill, somebody creating, enhanced tickler files to make sure that within the payer, timeline requirements that we're following up on that claim that it's getting with the payer. Then on any defects or denials that come in, creating an effective denial management strategy in order to be able to appeal those in real time and get the information to get the claim adjudicated. So that's historically what we've done. Moving into 2014, we need to create a better patient engagement modality, and that needs to start from the beginning. And how can we create that excitement and that engagement around the patient's experience with the provider and kind of model that similarly to what they've seen in other industries, be it allowing them to schedule their own appointments, seeing their bills, understanding their bills, and then moving into the physician charge capture component. I mean, this is going to be really critical moving forward, especially with the implementation of ICD10. Super bills are going to be the dinosaur of the past. I mean, they're going to virtually become extinct with the increased level of ICD9 or ICD10 diagnosis codes moving forward. From there, creating denial mitigation strategies to allow us to prevent that defect from occurring in the beginning, still having our billing follow-up, and then I'm replacing denial management with that of denial analysis. We should be looking at each of our defects and denials that are coming back and creating education and ways to enhance the engagement to get the information, better quality information from the patient, and how can we streamline and create tools to mitigate the denial moving forward. So we want to take this process and we want to surround it with technology and smart tools to build a knowledge-driven revenue cycle management program. A lot of the care industry today, you'll hear about, knowledge-driven care, to where whether it's drug-to-drug interactions or clinical care pathways that they're creating based on the knowledge that's been seen through the industry at the time, creating those workflow tools to take a lot of the memory away from the provider and the clinician that's providing the care. We can do the same thing within revenue cycle. I mean, we have the knowledge. So as we get feedback from our patients, physicians entering their charges, using those workflow tools and alerts to mitigate denials, and then when any defect is received, circling that back around to create what I like to call the appeal and prevent mentality. Appeal the denial the first time, and then hopefully you can put rules and education in place to mitigate that denial moving forward. So I want to start off talking a little bit about patient engagement and the role of the patient moving forward as a consumer. In the last 5 to 7 years, I think nationally we've seen around 11 million participant increase in high deductible and HSA plans. And that's continuing on with the creation of the health insurance exchange, to where consumerism is really becoming on a steady rise within the healthcare industry. I mean, we have legislation, private companies, and payers that are promoting cost of care transparency. And one of the things we're seeing is most of that responsibility and the cost of healthcare is initially being shifted towards the patient or the consumer. So what HSAs and these high deductible health plans have done is they've really got more of the patient's or the consumer's skin in the game, to where they start managing their health care in a more controlled environment. So how do we engage them as a consumer? Well, we need to look at ways to create interactive tools and to focus their utilization to gauge the patient and keep them engaged throughout the process. One of the key roles in the first way that we're going to interact with the patient is when they're creating their appointment. Historically today, appointments are made by phone. So you're already creating a limitation within the availability and the inconvenience to your patient or the consumer moving forward. So they're only going to be available to call and schedule their appointment while somebody at the front desk is available. So you're probably limiting yourself to 5 or 6 hours of available appointment making. That also calls into consideration when you're going to be calling in, that person's more than likely doing 4 or 5 other things, and initially would have to put the patient on hold. So that becomes costly to the practice. It's not a very good experience for the user, and it's not driving them as a consumer on how am I going to make it easier for them to access their health care and thus pay their bill. So one of the things we want to look forward moving in 2014 is how do we create that experience for patients via online appointment booking. Now this can be done in multiple ways. I've seen it to where we can actually establish and the patients can have a direct connect to the schedule and schedule their own appointments, or they can create and request specific days and times, and then the office provider can respond back via kind of the chat functionality. But what this does is this drives the patient to the consumers, and it's available for their convenience. So 24 hours a day, 7 days a week, the patient can go in, either their computer online, via their business, via their mobile phone, access their schedules, and create an experience to either reschedule or schedule the appointment at their convenience that works within their parameters. So this is not only going to enhance the experience, but also reduce the time and cost associated with the practices moving forward on creating that schedule. So when the patient goes in, you need to establish and set the parameters up to where you're capturing key communication modalities throughout the process. So we're capturing their cell phone account or their cell phone number. We're capturing their email address, and you can use that, and we'll talk about it more down the road, but key ways to communicate, market to your patients to ensure that, one, they're meeting their appointment, but are they maintaining their preventative care. And then it allows for consumer ownership, as I mentioned before, but it also drives the patient to your website. And when the patient's there, you create different marketing banners, alerts within the healthcare environment. If it's time for, you have your flu shot vaccine, time for patients to start scheduling that, you can prompt them there to just create some better engagement for the patient moving forward. So we've got their patients We have them in, they've got their schedule. How do we keep them scheduled? Medical group management or MGMA says average medical practices experiences a 5 to 7% no-show rate. Now that's been pretty consistent over the past couple of years, but what we want to do is focus on driving that down. Because obviously, 5 to 7% of a no-show is costly, it's time-consuming, it's frustrating for the office not having that booked appointment, but it's also frustrating for the patient. A lot of times the no-shows are just due to lapse in memory or not having a good mechanism to remind the patient. Some of these appointments are scheduled months in advance. If they don't put it on their calendar, they can end up missing it, and it's really no fault of their own. So what we need to do to enhance this is really create interactive tools for patient reminders. When the patient's going online to schedule, allow links to pop up to where when they click on it, it'll automatically integrate to their personal or their business calendar when booking online. So immediately they can start setting those reminders up front, and it's available on their calendar as they're running the rest of their life. And then we need to establish automated and interactive reminder messages through multiple modalities. A lot of practices today I'm seeing they utilize automated phone calls, and that works to an extent, but the patient isn't always readily available to answer their home phone or answer their cell phone. Who knows who gets the message when the message comes in, if it's actually captured by the patient or if it's just a reminder and somebody deletes it and doesn't pass the message on to them. So we need to utilize different modalities, including emails and text messages, and make those interactive. So when the patient or when the message comes out to the patient, the consumer, that says, your appointment, the reminder for tomorrow, please text back yes, or please email back yes to confirm that you're going to be there for that appointment, which is not just in the memory, but it creates a queue of engagement to get the patient to remind them, I need to make sure I show up for my appointment. So the next thing we need to do, as we've got them booked and we're going to ensure that they're going to be there, we need to ensure that as a consumer, they understand what their expectations are going to be. And if you look at it throughout the industry, as a consumer, our expectations have been molded by experiences that we've had throughout the industry, be it the mortgage industry, paying your car payment, paying your electric bill, paying your student loan. With this in mind, we need to create an experience for patients that is going to mirror that expectation. The first thing we need to look at is creating tools to allow patients to estimate their cost for service. As they become a consumer, looking at the cost and understanding what it's going to cost them to come in for the service is a key element. So you can look at this in multiple modalities, looking at specific procedures, flu shots, evaluation and management, new patient visits, and allowing them to create tools to say, this is the service I need to receive, what is it going to cost me? And then ensure from the start that we're communicating to patients what their payment obligations are going to be. That when the patient shows up, they're going to be responsible for paying their copay or any estimated services outside of what their allowed deductible plan is. Letting them know that up front so that you're creating that expectation that they're going to be obligated to pay their bill before they receive services. And then, communicating the terms and timing of payment expectations, as I mentioned before. If you're not going to pay it up front, then allow them to know that they have X amount of days that you're going to allow them to lag out to pay their bill and what their responsibility is going to be at that point. And then the last thing we want to do is promote tools, interactive tools for our patients to where they take the ownership and the responsibility to verify their own insurance coverage. This is a key element, and coverage-related and eligibility denials are one of the key things that plague most medical practices and revenue cycle entities across the nation today. And there's plenty of tools in place. Pushing that engagement, that ownership back to the patient is a key and vital role that we're going to take forward into the next step for the patient, ensuring that they're monitoring and being engaged in their care. So on those cases that we don't collect up front, we need to ensure that we're creating a clear and succinct communication to the patient on what their responsibilities are. In today's healthcare market, there is a fine line that's being ran between sufficiently informing your patients and overwhelming them about what their responsibilities are with too much data. One of the things that we can look at is enhancing your statements look and feel, as well as the delivery method in which you're delivering the patient responsibility communication. Will create a better experience for your patients, reduce calls into your office or your call center on questions related to your statement, and inevitably increase the velocity in your patient receipts to receive moving forward. The first thing we want to focus on is ensuring that our statements are clear and bold. So throughout healthcare today, most of your patients are probably seeing multiple providers across multiple specialties. Ensuring that your statement is clearly branded with your office and your logo, not only on the primary statement information, but also on the tear-off stub, will ensure quick and easy communication to the patient, that they can relate the date of service to the provider and to the office location and assist them in getting a clear line of sight of what their payment needs to be. You're utilizing legible fonts, clear fonts, font sizes, highlighting pertinent portions of the statement, related to the account, who the guarantor responsible is, what's the amount due, what's the due date, why is it due, and then the remittance address, which is key for the patients to actually submit their payments, and ensure that all those are clear and concise and readily available for the patient, and just upfront when they review their statement. Now, when we send this all out, ensuring that it's correct, we need to state only what is needed, and what is needed, or what is stated, needs to be correct. There's nothing worse that we can do from the industry and losing that patient confidence as a consumer than it is when we bill them an incorrect amount. So ensuring the quality of the statement, the quality of the balance is key in engaging the patient and keeping their confidence. And then don't limit yourself to just standard USPS. Create e-statements that are visible online where the patient can log into the logo and visualize the statements. Create electronic statements that are emailed to the patient where they have to go and log in, and then that could enhance their engagement with your website, as well as engaging them on enhanced modalities to create an electronic image of that statement and get a quicker payment in the door. So as we talk about a quicker payment, think about your experience today as a consumer, and how are you currently paying your bills? The majority of folks today are either through auto withdrawals in their mortgage, their car loan, they're going online and creating ACH just to pay their electric bill, their gas bill, their cable bill. Very rarely anymore are consumers writing out a paper check and putting a stamp on it. And the reason that is most of the organizations today, in order to cut costs and enhance their payment cycle, are driving the consumer to pay their bills electronically. Us as a healthcare and treating the patient as a consumer needs to enhance our modalities of patient payments, which is going to be vital in creating a positive experience. Driving the patient to pay their bill online has a lot of advantages for the patient and the consumer. It's fast, it's safe, and it's easy. It's what they are doing today with the majority of their outstanding balances. It allows them to automate withdrawals from their current checking account or utilize a credit card to pay for their statement. It's the go green thing to do. It meets with the environment. We're not wasting a lot of paper. It allows them to easily consolidate and easily organize all of their patient responsibilities, and then at the end of the year, from a tax perspective, they don't have to be asking you for their payment. They can actually go into the portal and drive down and get a listing of all of their medical bills they can use for tax purposes. But it's not only advantage for the consumer. It's a lot of advantage for the practice as well. It's obviously going to reduce the staff expense associated with return remittance advices and mails that you have to have somebody open the mail, somebody pull out all the check information, somebody take it to the bank and deposit. So it's going to increase the velocity of payment, because pushing those modalities and allowing for that payment online one-time takes the lag out of the postal service, but also allows them, from an engagement perspective, to actually pay their bills quicker. The practice is going to have quicker access to the funds because the payments are actually automatically going in at the time in which the services are paid for. It allows for auto withdrawal and payment plans, and this is really critical as well, because allowing your patients to establish payment plans is something that most practices do, but it creates that memory and that lag in the payment, where if you can create auto withdrawal payment plans to establish your patients the date, times of the month in which their payment balances are going to be allocated, is going to create a more streamlined and a consistency and a standardization in your cash flow. And then obviously, it reduces statement and postage costs for from the practice's standpoint because you're not having to pay for that return address. The next thing I want to talk about is, from a consumerism perspective, is what are ways and techniques that we can grow our volume. Ensuring visit attendance is only one way of enhancing your revenue cycle for your process, but instituting a recall and looking at preventative marketing strategy could be a vital lifeline in maintaining practice revenue optimization, as well as enhancing the care management for your consumers. From a recall perspective, looking at chronic disease management, where you're going to have patients that are either going to come in on an annual or a semi-annual or a quarterly basis to look at their diabetes care cycle, their asthma care cycle, looking at mental health treatment plans, or just some of the ways that you can create recall letters, recall reminders that automate and engage the patient to ensure that they're maintaining their preventative care measures and driving that visit portion back to your office. One, it's a good quality of care, but two, it also ensures some consistency and sustainability in your practice volumes. The other thing to look at that is missed at sometimes is looking at health assessments and how can you market out to your patients to ensure that patients are coming in to do routine medication reviews, ensure that their medication population, their medication amounts are working effectively. Preventative health checks in children. Looking at your Medicare population and seeing who in the last year hasn't had a Medicare physical, marketing to those patients to come in for that preventative care. Looking at your pre-risk diabetes patients, comprehensive medical assessments. All of these tools, can limit and help you drive volume back to your practice, but also create a preventative care, update for the consumer. So as we move into the front-end processing, as we mentioned before, that patient coverage can change from visit to visit. And ensuring their coverage is essential in preventing eligibility and coordination of benefit denials, and also ensuring copay and deductible amounts are accurate and understood. Automating this response is going to be key and vital. Now I'm going to mention here 270 and 271 responses. Those are the industry names. The 270 response is actually the request that we're putting into the insurance company to say, does this patient actually have this coverage? So we're sending them the patient name, the date of birth, their subscriber information, and then the 270 is their response back to us stating, yes, this patient is eligible, or no, it's not. And if it's not, they a lot of times will give us information to say the date of birth doesn't match, or we can't identify the patient. So what becomes critical, as this is one of the highest denial rates that are seen across the industry, is alerting and creating flags to identify these demographic capture errors in the scheduling process. So whether it's online and a patient entered their information incorrectly, or if they truly don't have this insurance anymore, or just somebody manually keyed it in incorrectly, we want to create an alert and an edit up front throughout the entire checkout process to ensure that the visibility is there, that they need to correct that defect before the claim goes out the door. As you can see in the example here, Jody has a red exclamation point, which really triggers and flags. What we want to do, creating consistency across the board, is whenever that defect is there, we don't allow the claim to go out the door until the defect is removed. And then the other thing that we want to look at from an eligibility, one of the added benefits, is identification of patient responsibilities. This varies from payer to payer, but most of the information that will be there will actually communicate what the patient's copay or co-insurance responsibility for in and out of network, and how much of their deductible has been met. This becomes really critical and key when we're looking at estimating services to understand what the estimated cost is going to be for the patient and how that relates to what their outstanding deductible balance is going to be. So I also want to get in here, as we talk about ICD10, the time is fast approaching that physician super bills are going to become obsolete. If we look at a typical family practice super bill of 100 to 120 ICD-9 codes, with the implementation of ICD-10, those are going to grow to over 700 on average. Obviously, you won't be able to put 700 ICD-9 codes on a super bill, so we need to work towards developing and implementing an electronic and streamlined charge capture at the point of service in order to maximize our revenue. So as we get the providers, and a lot of providers are going to get pushback, some are going to be more readily available, but regardless, we need to create system tools and solutions that allow for quick and easy searching. Keywords, abbreviations, nomenclature, search engines to allow the provider to easily identify the diagnosis code is going to be key to getting the provider to buy in and to utilize the system to do their own coding. One of the things that the providers doing their own charge entry, it's going to enhance the complete capture of services provided, that things aren't missed within the super bill checkoff, or that somebody doesn't enter a charge as they're going through the super bill. It's going to create for a more enhanced capture of all the complete services that are provided and allow for us to ensure that we're billing out the appropriate amount for the services that are rendered. It's obviously going to decrease the lag in charge submission, which is going to increase the velocity in your payment cycle. And it should help with, enhancing, the limitation of potentially missing charges as it relates to either the super bill getting lost or somebody not reading it correctly. And then lastly, it allows point of service edits and consistent provider communication back to the billing department. What's key here is, if you can identify a defect up front, or if you want to communicate PQRS information, doing that back to the provider at the time that they're entering the services is going to create a better engagement and create quicker turnaround time to where things aren't missed. As well, that online documentation and that online modality allows for consistent provider communication if there's any questions or concerns in regards to the billing from the provider to the billing department or the billing representatives. So when we look at efficient processing, obviously creating a front-end collection strategy is going to be key and vital. As more of the responsibility moves back to the patient, you're seeing it in the deductible periods that are actually coming out now in 2014. And as the deductibles are higher and more patients are moving to a higher deductible plan, the length of time for those deductibles to be exhausted are going to be longer, thus delaying your cash flow. Setting expectations via on-site during the scheduling process is going to be key to allow the patients to know that they're going to be responsible for their payments or their estimated services at the time of service before they're actually seen. You can educate your staff on effective ways to request a payment. There's a lot of key things. How would you like to pay today? Would it like to be via check, via credit card? But setting that expectation up front so that the consumer understands what their roles and responsibilities is going to be key from a front office perspective. The other thing that needs to be done across your practice is really know your payer population. As the implementation of the health exchange plans are going out across the nation and we're getting more participation and more patients sign up, we're actually seeing variations within the same plan on their copay structure depending on the status in which the provider of the practice is in. So knowing that population, understanding what your patient deductibles are they on just a high deductible plan, are they on an HSA plan, knowing that and knowing what the responsibility of the patient is going to be is going to assist further in setting that expectation and collecting that money up front. As we mentioned before, cost estimation tools for your key payers and your key services provided. This is an element that is going to be really beneficial, especially relates to the high deductible plan when you start looking at, an evaluation management service or just a typical office visit is going to, pay me $74. That's just on average. So I'm going to look when this patient with this insurance comes in, we're going to estimate that service out at $74 and we're going to request that payment up front before the services are provided. Understanding and setting that expectation with the patient that this could be more, it could be less, but this is on average what you're going to experience, request that payment up front. Obviously, you want to collect copays and estimates, but you want to do it prior to the services being rendered. A lot of times at checkout, you can create effective processes, but if that person is doing too much or they get up from the desk and somebody looks to go out without collecting that money up front, you have the potential for it to walk out the door and delay the cash flow from coming in. And then for those opportunities where you're wanting to establish your payments up front, and patients, some patients aren't going to have the ability to pay at that time, establish your payment plans there at the point of service to where the patients understand their expectation and when the automated withdrawals are going to happen. You can work with them on, how often, how long you're going to allow them to pay it out, what the minimum monthly balance is going to be, and then work with your patients on, do they want to take it on the 15th of the month, the 12th of the month, whatever day it is, but let them know from an expectation perspective that you're going to be taking that withdrawal to where you'll have accessibility to the funds. Lastly, I want to talk about PQRS. I'm sure most of the people on this call are using the quality reporting system. If not, we need to get on board if you're eligible professionals. Eligible professionals consist of physicians, practitioners, and therapists that bill Medicare. 2014 is the last year to report to receive the bonus if you're an eligible professional, but 2015, if you're not submitting, you're going to start seeing percentage payment adjustments for noncompliance and reporting to the quality industry. If you're not submitting it, we need to start looking right now to get you on board to where you're actually you're submitting it. Now, there's two ways to report to PQRS. What most providers have done in the past is the single claim registry. So every time one of your eligible Medicare populations were seeing that they met the qualification, you would just submit the PQRS code along with the claim. In 2014, a lot of the measures have actually moved from single claim to qualified registry submission, which allows for a greater modality and enhancement of the available registry components within the domains. One of the key changes as well in 2014 is it's no longer 3 measures at 80% of the time. You have to find 9 measures across 3 of the clinical domains. You have to report on that 50% of your eligible population for the entire calendar year. Now, one of the other things to really keep in mind is that automation and that engagement from the provider's perspective, so that they don't have to remember what they're doing, creating those front-end edits to enhance and prompt the provider that this patient is a Medicare patient that meets your diabetes modality in this domain. You need to be able to say that you did X, Y, and Z. And pushing and prompting that information versus somebody just remembering to code that CPT code or track against that from a registry submission perspective is going to be key and vital moving forward to ensure that you're meeting your minimum of 9 measures 50% of the time, but ensuring that you're not getting are going to come up against an adjustment or a penalty for noncompliance moving forward in 2015. Now, one of the last things on the front-end processing I want to talk about, and I mentioned this earlier, is really focusing your attention on denial mitigation. Historically, the revenue cycle has been focused on billing claims and then, worrying about how do I efficiently manage my denial volume and how do I appropriately appeal, make changes to try to get the claim adjudicated within the limited amount of response time that the payers allow us. Obviously, this leads to delay in payment. It increases your bad debt, and it creates additional expense because you're having to work and touch the claim multiple times in order to try to reach adjudication. So what I want us to focus our attention on is really how do I mitigate those denials and focus more on prevention versus appealing. So we can do this, it's a powerful tool when you use an automated claims and rule scrubbing engine at the time of the charge entry process. So what you create is this elimination of the memory requirement and an automated trigger response that's built into the system and into the process to where when a provider is entering their charges, it's looking at key mismatching or key modifier requirements. And you're building this, you build your edit specific to the provider as well as the payers. So if Dr. Smith and United works differently than a different doctor in the practice, you can build the edit and really relieve and eliminate the memory component of the ones that are doing the charge capture. The edit is going to create alerts and direction, so as the edit pops up and says, you may need a modifier to support this being an independent procedure, and it gives you some direction associated with that. So just not leading them, but also telling them and educating them to prevent future enhancements. And then it prevents claim submission until the defect is resolved. And if you look at and you kind of mirror it to some of the other industries. I like to look at manufacturing as one of them. If you look at the manufacturing industry, they have different checkpoints and different operations when you're building a car. So there's going to be somebody putting on the chassis, somebody at the doors, somebody at the tire. And then they have checkpoints built within that assembly line process to prevent defects from occurring before the car, the truck, the SUV gets off the assembly line and is out into production to be sold. Well, in our market, it's not much different. But instead of completing a car, we're actually a clean, payable claim is the result that we're wanting. And the patient engagement and the interaction and ensuring that the quality information is there, we need to have checkpoints in place because it's a lot more costly for us when we submit a claim with a defect to try to get that defect resolved and paid than if we just prevented the defect from occurring and the claim going out the door before the defect was corrected. So some of the examples of type of prevention denial edits, these are just some global ones. Looking for services requiring authorizations or referral, and not doing that at the time of charge entry, but actually putting that edit on the front end. So at the time of schedule, when I'm doing this procedure, it's going to require an authorization or a referral from the patient. Prompting that for the patient when they're creating their schedule, as well as for the front-end staff when they're checking the patient and creating the schedule, that they know ahead of time that the authorization is going to be required. We already spoke about eligibility and insurance verification, looking at local coverage determinations, exclusions, diagnosis of CPT inconsistency. How do you use your modifiers, bundling and inclusive procedures? Looking at vaccination administration capture. What I see a lot on missing charges is that we'll remember to bill the drug or we'll remember to do the administration, and sometimes we forget both. So just creating that prompt to say, I see that you billed an administration code, but you didn't put the corresponding vaccine or drug, is a way to ensure that you're capturing all of your revenue and minimizing any denial opportunities. So the next thing I want to get into is managing your provider credentialing and enrollment status. Often lost in the evolution of revenue cycle management is the necessity to develop an effective process to monitor and keep current your provider's credentialing and their payer participation status. Many of you have probably already started to feel some of the effects of the Medicare revalidation. Where are they sending the letter? Who's getting the letter? Are we getting it in a timely manner? Ensuring that we can start the revalidation process. And this is occurring primarily with Medicare, but we're also seeing it with some of the coverage and participation limitations of some of the commercial plans as well. Most practices, what I've seen, lose line of sight and really don't have the time or the resources to appropriately manage this constant change in status, navigating all of the different state and payer requirements. One of the benefits that you can have here is partnering with an experienced organization that will be key to managing your provider participation. So getting with someone that's going to have knowledge on specific payer and state requirements, understand the paperwork, understand the time frames, know and be able to navigate to get you the quickest turnaround time so that you can actually start billing and being compensated for your services. Tracking and monitoring recertifications and quarterly revalidations, managing and communicating the status of the enrollment back to the practice as well as the billing organization to take that ownership to ensure that your participation status is held in effect. So as we move to the back end and you think about it, there's really two primary reasons that a claim doesn't result in payment. The first one is you submit the claim and it's not received by the payer. And secondly, it denies due to a defect. Now, on the first one, there's things that can mitigate to ensure that your claim submission is on file with the payer. And creating automated status verification is one of the things that can assist you in streamlining your follow-up activities to eliminate that claim not on file response when you're following up. So as we know that the claim is on file, if you don't get the response back that is accepted, you can resubmit the claim. If it is on file, then that can help you streamline and strategize your follow-up to where you haven't received response. And also, as we spoke before, as it relates to number two, you replace your denial management with denial analysis. Utilize your human capital to research and identify the opportunities and the defects that are currently coming into your practice. As I like to say, adopt that appeal and prevent mentality. So as the denials are coming in, you're reviewing them on a routine basis, hopefully as the denial is being posted, at a minimum, I think, on a monthly basis to go back and look at your denials, but taking that information to build preventative techniques in place, using that knowledge to drive the process to the front end to ensure that we're mitigating that denial the next time. So you appeal it the first time to ensure that we're getting payment, but then you create those preventative mechanisms to where you don't have to deal with that denial for the same time moving forward. You know, one of the things that's key as well is looking at your payer contract compliance and ensuring that your payers are paying you to the contracted rates that you're entitled to. You know, most payers have all of their providers loaded in, and it's all an electronic adjudication process itself. So there could be edits built in, defects built into their system that we have to be on top of to catch. So if you look at commercial payers on average, they're going to underpay on about 7% of their claims. And this becomes real money. You start talking about over the course of all of the payer process, you're talking about thousands of dollars of cash flow that are potentially lost on an annual basis simply for the fact that we're not tracking and monitoring our payers to ensure that they're paying us the rates that we deserve. So one of the things that we want to create, I'm going to go back into automation again, is we need to create systems and a knowledge repository on the fee schedules to prompt when we're posting an allowed amount that differs from what reimbursement rules in the fee schedule of the specific payer populations are, to prompt us to create an appeal mechanism to go back and collect the full amount that's due. So obviously, as we discussed, creating system flags and alerts to identify those underpayments, but when you go in to make the appeal, one of the best things that we can do is create that individual appeal. So when we've isolated down to one or two specific types of instances, create one or two appeals, allow the payer to set the precedent that, yes, their system was in error, that they should have paid at a higher rate. And once you have the payer that set the precedent, then you can follow back up with a bulk appeal on all of the same corresponding line items. So finally, one of the last things I want to get into is ICD10, and unfortunately, it's not going to go away. This is becoming really a reality. As I talked about before, this is the biggest change to face our industry in decades. We've been using ICD9 for about 30 years, and basically everything we're doing is changing, and the disruption is going to be real. Just some housekeeping. I mean, the diagnosis is increasing from 5 to 7 characters. There's no longer going to be a decimal point. It's going to be alphanumeric. Documentation from the provider is going to be critical. Creating complete and concise documentation that focus on the specificity of the injury, the location, the laterality. Understanding those and documenting those are going to be key in, one, selecting the appropriate diagnosis code, but also mitigating any denial opportunities. You know, as the codes are multiplying exponentially in the amount of diagnosis codes, that's also going to increase the amount of local coverage determination edits and rules that are going to be required to eliminate and alleviate that specificity from the diagnosis capture perspective. If you haven't got your billing and coding staff to start the training and recertification where possible, we need to start that now. I mean, we're really down to about 8 months before we're going to be going live, and this is going to have a real critical impact to your organization, to the provider, and to everyone. So anticipate delays in cash flow. It's going to more than likely happen. If you look back over the past couple of years when we implemented 5010, the majority of our payers, I'll say a lot of the payers still weren't ready to be able to accept the new format in the 837 file. I would anticipate that some of our payers are probably either going to, one, have errors or not be ready to be able to submit the ICD10. This is going to call the delay in cash flow, and I just want to make sure practices are ready and looking in advance of that to start having more days cash on hand in order to be able to anticipate the cash flow and not have to take out lines of credit in order to be able to produce and pay for their business until the insurance population and community gets up to speed. So with that, I'll wrap up a little bit. Thank you all for taking the time. We want to make sure that we're embracing our patients, engaging them as the role of the consumer in the healthcare market, surrounding your front office and your back office with tools and technology that are going to streamline the patient experience and reduce the claims defect. We don't want the claim to go out the door until we ensure that it's clean and it's clear of any defect. Using preventative treatment plans and a recall strategy to help grow your volume, to pull your patients back in, to get that engagement from them. How important it is to manage your provider's enrollment status, monitoring your payers and holding them accountable for ensuring that your contracts are being monitored and adjudicated correctly, and then increasing the visibility and preparation for your ICD10. It's going to be critical. We're only 8 months away. And with that, I'll open it up for any questions.
All right. Thanks, Mike. I really appreciate it. Great information. We do have some questions that we had sent in during the call. We have quite a bit of time left here. We should be able to get to all of them. In the meantime, if you have not submitted your question yet, in the GoToMeeting panel on the right-hand side of your screen, there is a questions section. You can enter any questions there. Just a reminder, everyone will be receiving a copy of this webinar via email later today. The first question, Mike, that I'll give you is someone was asking probably around the time of the capturing people's payments, how do you set up auto withdrawal? Do you keep a copy of the credit card on file?
Yes, that's typically how you can do it. Patients can either work with their existing bank to set up that ACH auto withdrawal, or most of your online portals to allow that capture will give the option for the patient to keep their credit card on file.
Okay. This is specific to a state, but it may apply to other ones. Here in New Jersey, the largest commercial payer has a posted policy prohibiting providers from collecting deductibles or coinsurance at the time of service. Is a payer really allowed to prohibit providers from collecting what is due? Is that enforceable?
I'll have to look specifically, and I can look up New Jersey. I don't believe that is an enforceable rule. Do we know the payer specifically?
Not within this question.
Okay, if we could submit a follow-up question to that, and we can follow back up with you. I don't feel that that's going to be an enforceable process, because that's obviously delaying, and it is going to be a responsibility of the patient. So there's really no different collecting it up front than just waiting 30 to 40 days before they get their statement.
We did get a response back. It's Horizon Blue Cross Blue Shield.
Okay, I'll look at that and follow up. I don't feel that we're going to have to alleviate ourselves to not collecting that up front.
All right, perfect. Thank you.
If we have their contact information, Leonard, I can follow up.
We do, and we will follow up on that separately then. Let's see what else we have here. The next question, what increase do you typically expect in patient payments with an online portal implementation?
Oh, that's a good question, too. Typically what we see is, and it's over the course of a time, but what I've seen historically is 15 to 20% an increase on patient payments. Some of that is related to the fact that you're enhancing the modality and you're actually making it easier. And as you engage them, they're more tuned to paying their bills quicker, and plus you don't get the, I got a statement and I left it off on the table. But obviously, as the payments are coming in quicker, the reason I say over a course of a time is, since you're getting that payment quicker, you're actually, if I measure it for an 8-month period, you're actually collecting money at a faster rate than what you would have, so you have that availability. So long answer to a short question, but we see around 15 to 20% increase on patient payments for a practice.
Okay. The next question, if a patient continuously puts off paying a balance, what actions can take place to enforce payment, and within what time frame?
I'm trying to, I'm not sure that I'm understanding the question.
It looks like they're saying if a patient is not paying a balance, they owe money to the practice and have not paid it. What's the time frame to still try to collect it, and what type of actions can they take place or can take place to try to collect that balance?
Well, I would recommend if patients aren't paying their bill, we're kind of held for the Fair Debt Collections Act. We have to notify them, a particular portion of time. So if patients haven't, what I recommend is if patients haven't met their responsibility after 90 days, I would look to engage in a collection agency. They can take different tactics than either a billing provider or a medical practice can do to help effectively collect that outstanding balance.
Okay, perfect. How do you recommend estimating the price of services for patients?
Yeah, that's a good question too. I mean, it really comes down to the practice and the specialty. One of the things that I've done with a lot of my clients is we'll actually look at what are their top payers. So I mean, if you take their top 5 or 6 payers, you're more than likely going to hit about 90% of their population. And then also estimate that down and break it down into what are the services that we're providing. So if there are procedures, what is the estimated allowed amount for each of those payer populations? If they're coming in for a flu shot, or if it's a cardiology practice, and we're going to look at ECGs. Those specificities, I mean, we're going to know the allowed amount that we've been paid on those because we're going to be monitoring our contract compliance. So knowing those allowed amounts is going to help us trigger what the patient's going to be responsible for. And then I would also look at, from an evaluation, if a patient's just coming in for a standard office visit, just look at your mid-range levels. It should meet the majority of the collection. Sometimes it may be more, sometimes it may be less, but at least gets you some of that upfront cash flow from the beginning.
Great. Another related question, what do you do about patients who do not pay their late or no-show fees, Medicare and Medicaid patients especially?
That's a really good question. So you're charging a no-show fee right off the bat if they don't show up, and that's a part of your policy. So have you set that expectation with your patients?
Yes.
Yeah, Medicaid's a tough one because we're never, it's hard to build the Medicaid population. When you send that out, are you seeing any type of feedback from your patient population on making those payments?
Give her a moment to respond here. While we're waiting for an answer back on that, if there are any other questions, please submit them. We are running a little low on time, so this will probably be our last question during the session, but all the other questions that are entered will be responded to directly from someone with MD Everywhere. The response came back, it's charged directly to the patient, not the insurance, for the no-show fee.
Right. So I mean, you're submitting that on the balance. I don't know that it's outside of going after them, and if you set the expectation, billing them for that balance, and that's your practice's policy, and you set that expectation, then it would be no different than any other patient balance. I would be careful with the Medicaid population, but any other payer, you can go after and pursue that balance as you would any other patient balance.
That's great. Yeah, if a patient is signed for understanding there'll be a fee, they are definitely responsible for that fee. All right. Well, we thank you, everyone, for all your time today. We thank you for attending. We will be sending out again via the email that you registered for the session with. We will be sending out this webinar. It's also going to be available on our YouTube page. MD Everywhere is the keyword to search for in YouTube, and you can view all of our videos there. If you do have any questions, our contact information is on screen. Please feel free to reach out to us with any extra questions that you haven't submitted today or that you think of later. And again, we thank you for your time today, and Mike, thank you for your presentation.
All right. Thank you, everyone.